Whatever happened to my GP? One of the cornerstones of general practice and one of the major drivers of the efficiency of the system of general practice is continuity of care. And unfortunately, with the different ways in which GPs are working, with more people working part-time or with portfolio careers, as well as with the varied clinical workforce we have within general practice nowadays, this continuity of care has been increasingly difficult to deliver in the pressures of today's general practice. It also seems that continuity of care is going to be the latest political football, with Labour saying that when they take power, they are going to be looking at ways in which they can incentivise continuity of care in primary care. So, if continuity of care does improve efficiency and is going to be one of these big political footballs, it makes sense for us to look at how we could improve the continuity of care within general practice and within our own practices now. I'm very much believe that by the end of this video, I'll have given you some actionable things to take away and look at in your own practices that might help to improve the way patients are seen by the same person when appropriate. But before we go into the how, let's spend a little moment thinking about the why. What are the benefits of the continuity of care that used to be so commonplace within general practice? Obviously, there's a stronger doctor-patient relationship. That increased trust allows both the doctors to take certain safe shortcuts with patients, allows them to reassure them more appropriately and more rapidly, reduces the amount of over-investigation that goes on. I think we can all remember at least one patient who's come in having been seen and worked up by a colleague, comes to see us for the same thing, and we go and order the same test that's already been done, but the patient's already forgotten about it. And frankly, digging into the electronic record, you're likely to have missed that one thing that's been done previously. This is clearly not an efficient use of our time, NHS resources, or indeed the patient's. Patients who get seen by the same doctor also tend to report higher satisfaction, and we know that our lives is always considerably easier if our patients are happy. If our patients are happy, we have fewer complaints to deal with, and in general, they take a lot more understanding of the situation that we find ourselves in terms of accepting longer waits, etc. And finally, we know that there are improved health outcomes for patients who get seen by the same clinician on a regular basis. How do we make up for the lack of continuity now? Over the last several years, we've had to rely on the electronic patient record and the notes of our colleagues to get us through. A quick look through the previous notes for the patient just before you call them in, hoping that that will bring you up to speed with what's going on for the patient. Let's spend a moment thinking about some of the ways that continuity of care or improved continuity of care is managed in general practice now and what we might consider acting on in the future. The first one, and the old standard, is of course strict patient lists. This is often how general practice was performed and how the original continuity of care and doctor-patient relationship was built up. You saw your GP on a regular basis, and they were the one who knew you, knew your family, understood the quirks of your health, how you present with various problems, and could help you deal with those in the most efficient way. If you're able to do that as a practice, that's great, and it's clearly one of the strongest ways of doing it. However, there are significant challenges to this. More and more GPs having portfolio careers or working part-time means that there is much more difficulty in booking people in a timely way with their own GP. Also, we now work with paramedics, nurse practitioners, etc. We have pharmacy first. We have a range of different options that our patients may benefit from seeing, and certainly not everyone presenting to general practice needs to be seen by a GP. It also tends to lead to increased wait times for patients as they have to wait longer to find the slot with their own GP. And finally, I think that there are cases where patient lists have developed for certain doctors where they then find themselves with a list of patients who are perhaps more difficult to manage because of their own personality type, and that then means that this is more difficult and can lead to increased risk of physician burnout. The next way that some people talk about increasing continuity of care is, of course, booking your patients yourself. When you've seen them after one appointment, you book that appointment for them for the next appointment that they need. Unfortunately, this of course requires you to know when they're going to need that appointment. It's fine if you're arranging some arranged follow-up and you know when the tests, for example, would be back. However, very frequently, you're not going to know when a flare-up of a condition is going to occur, when a patient is going to need follow-up with you, and it therefore means it's much more difficult to book that patient back in at a time when they want it. And of course, they're then going to have to call in when they feel they need the appointment, and that breaks down that system at that point. Another issue that you can find with this is that the temptation is to book patients in more frequently than perhaps they need to be seen. This is either for reassurance of the GP themselves or to reassure the patient because they know that it's going to be more difficult for the patient to book the appointment. Or of course, you might find that if a GP is under significant stress, they might find themselves booking in patients which they know are going to be more straightforward for them to deal with in that moment, and of course giving them more time, but of course reducing the overall capacity of the practice. The next one is, I think, a very interesting one, and it's something I've seen done quite effectively at some larger practice. This is where you cohort patients into those who are going to require or are likely to require more continuity of care. Our patients with multi-morbidity, patients who are more frail, who have a diagnosis such as cancer, or have been identified using various tools which are out there as being patients who are going to need a lot more input from a GP. These patients are then flagged and they are then dealt with by their own clinicians or clinical teams, depending on the setup of the practice. Something which I think we could all agree is a sensible way of managing things. The other way of doing things is by buddying up clinicians, or indeed bringing together groups of clinicians that own a section of the patients within a practice. This can be effective in that you are more likely to find a patient being booked in with the same GP or the same clinician on a regular basis because there are fewer clinicians for them to choose from when they're being booked into their group within the practice. This of course doesn't, however, guarantee they're going to see the same GP. It's just a way of increasing the chance that that happens. And hopefully also there's an increased communication between the various members of a particular cohorting group of clinicians, which allows them to talk to their colleagues about patients who are likely to need more input and perhaps make sure that things are carried across and followed up between them. I have also seen systems whereby the cohorting of patients and the grouping of a clinical team have been brought together to try even further to improve continuity of care. Now we come to the final version of improving continuity that I'm aware of and I'm a massive advocate for, and that is total clinician-led triage. In this, the incoming requests for clinical input from the patients comes into the practice and is assessed by a clinician. The clinician will look at what the presentation is, what the request from the patient is, and they can also look briefly to see if they've been seeing a clinician specifically about this problem or about other problems more frequently, and they can then try to book them in with that doctor or paramedic, whoever is appropriate for dealing with that case. They are also able to tell which conditions could be safely seen elsewhere or by a different member of the clinical team, such as one of our paramedics or nurse practitioners for a more acute issue. And then finally, they can also make a judgment on how safe it is to leave a patient for a particular length of time in order for them to see the same clinician and to improve the continuity. If you want to learn more about clinician-led triage, please check out the video linked here where I talk more about it in depth. I'd love to hear what you do in your practice to improve continuity of care, how you get your patients seen by the same people. Please leave those in the comments. I'd love to hear. If you have any other questions, again, leave them in the comments.